fempop graft thrombosis or other grafts, viabond thrombosis or in-stent restenosis with occlusion. You kind of get the restenosis and then you close everything. And CTOs. A lot of CTOs started out short but became very long because of thrombus. So these are all times when we find ourselves trying to deal with thrombus and kind of some strategies. Just a few quick notes. DVT, you know, it's a big problem. At least 600,000 new DVTs every year, and it's quite a morbid problem. At least responsible for 200,000 deaths every year. And it's really, if you kind of see how your hospitals, when they get good quality improvement things going on, they're really focusing on preventing DVTs for a good reason. It's a preventable death many times. And you know, all these are known, the precipitating causes of DVTs. Really, a combination of Virchow's triad here, and you know, some sort of trauma, some stasis, inactivity. We worry a lot about cancer. In some of the trials, cancer doesn't really make up a huge number of patients, but it's definitely a risk. But definitely inactivity, long car rides after, or the combination of things, smoking, contraceptives, and surgery. It's a common thing where young women we see with DVT. So kind of adding these up is helpful to understand the causes and the risks. I mean, these are kind of the same list, but age has something to do with it, cancer and obesity, as I mentioned. And kind of, so we find out later on, usually maybe some family history as well. Then you can go into all the different hypercoagulable states that might be out there. And as you know, most DVTs present with swelling. It's a venous outflow problem, so the limb gets swollen. It can be tender, it can be painful, it can be reddened. Maybe some pain on dorsiflexion. You might start to see some collateral veins on the around this if they've had time. And if it gets really bad, phlegmazia cerulodolens, you may start to lose your arterial pulses. We had a case of this recently where they were just very severe all the way to the inferior vena cava, and then they start having arterial problems. So what complications can come from the DVTs? Well, one of them, the biggest one, the most serious, is pulmonary embolism, obviously. That's the high risk thing. That's what people die from in DVTs. But post-thrombotic syndrome is a big deal, and that's kind of where we come into play. Because I really think being aggressive with treating DVTs, besides just medical therapy, this is where we can make the biggest difference. And I think that, you know, we have to understand about a third of people with a DVT are going to get post-thrombotic syndrome. It's really what they have is a persistent swelling, heaviness in the legs, exercise intolerance. They have paresthesias, cramps, pruritus, all the things you might get with severe venous reflux, but actually you have deep venous occlusion or persistent valve dysfunction. And the risk factors for this are recurrent DVTs in the same leg is a problem. Age, sex, hypercoagulable state, obesity, immobility, all those kind of add to it. Because if you don't have mobility, you don't have a calf pump working, you're going to get more and more swelling, and it's going to stay that way. And really, an unprovoked DVT at a young age, at old age, is the problem. And this one thing, I never checked this, but interesting, a persistently elevated D-dimer for more than 4 months seems to portend a higher risk for a post-thrombotic syndrome. So to me, I think this is a big deal. This is where we can really make a difference for people. And there's been a few studies. I'll quickly show. One was a meta-analysis looking at 3 different treatments: systemic anticoagulation, just medical therapy, surgical thrombectomy, and catheter-directed thrombolysis. And they really showed that if you look, either way you look at it, if you take the surgical thrombectomy, which I've never seen, but I'm sure it's helpful, you're going to have less post-thrombotic syndrome, less reflux, and less venous obstruction. There is a treatment benefit to doing that. And the same thing, if you compare thrombolysis to medical therapy, you're going to get the same thing. You're going to have an improvement in each of these big deals. So there is some definite treatment effect. In another trial, Torpedo trial, looked at this, looking at a percutaneous intervention versus medical therapy. And you can see they showed some rather impressive improvements here, 2.3% of a recurrent clot versus 14.8% with medication alone. And the post-thrombotic syndrome was quite dramatic, almost 30% if you're medical therapy versus maybe 3% if you had some intervention. And there's another one here, a CVC study, similar improvements compared to for iliofemoral DVT, catheter-directed thrombolysis. They did kind of quote a kind of a high bleed rate, so it kind of points out that, which the other ones really didn't. You need to be cautious and learn how to do this in a way that doesn't cause more problems. So what do we do with catheter-directed thrombolysis? Basically you want to get past the occlusion if you can, even though upstream from a thrombus is sometimes useful to help get it started, but usually you really need to be in the thrombus and across it. Use some form of infusion catheter. You might want to use a micromui if you have to. And right now I think most people use the alteplase 0.5 to milligram an hour. DVTs tend to use more of the higher dose for these. And the relook time is, it depends. And arterials, maybe you can get by with 3 or 4 hours. Venous is going to be longer. And that's kind of what we'll talk about combining therapies because it can be quite frustrating, a multi-day infusion for a DVT. So you want to think about possibly this. Using some sort of mechanical version to help you. Now, AngioJet is one that we've used for a really long time. AngioJet will help remove the clot, and it can be a nice adjunct, as we'll see, to thrombolysis as well. And I bring this up because I just saw a case recently where they were showing me the case, and I go, "What did you do here?" Like, "Oh, well, I used an export catheter." I'm like, "What are you doing?" Export catheter is made for the heart, for a 2 to 4 millimeter artery. What'd you put this in an 8 millimeter femoral vein? It's not going to do anything. You might as well just throw it on the floor. It's going to do anything. So that's my point. You really need to and actually I see people pull a coronary AngioJet, put it down the leg. In an 8 millimeter artery or vein, it's not going to do anything. You have to match the size of the device to the vessel you need to treat. So the Solent Omni and Proxy devices are the current ones for the bigger vessels, and you just need to be aware of what's there. If you don't do it very often, make sure you look at it, make sure you got the right one, because these can be quite helpful. I think the little movie that explains this isn't there, but you can kind of see on this. This is basically, AngioJet is a shower head, basically. I'll show it over here. So the water's coming down a little tube, 300 miles an hour here, hits this little circular shower head, and it shoots back from where it came. And when it shoots back across these openings, it creates a low pressure zone over those openings, and that's a Bernoulli effect, and it'll cause entrainment of thrombus. And then it has these little holes where it shoots out against the walls to break up the thrombus, and then it entrains it. So that's really how it works. It's a super water pick, I guess, more than a water pick. Causes actual suction. So I think they took them out. So the device basically will help take out loose thrombus and try to break up some of the other stuff. Let me show you, there's a couple other devices out there. I wanted to talk about AngioVac, because you may be hearing a little bit about AngioVac. AngioVac is quite interesting. It's designed for big veins, inferior vena cava, big common iliac veins, or the heart, pulmonary artery. It's quite wild. It uses the extracorporeal bypass, venous cannula, to actually remove thrombus and block. So you actually get the bypass machine, get the perfusionist in there, put in a venous cannula for return and the big cannula to remove the clot, and you basically drive that up to the IVC. So this is a little bit of a commitment, but it's quite interesting. And so here's a device that's got this balloon actuated tip here that's a funnel, and you need, and this is sort of stuff you can get out, you need the funnel to create the vortex to actually start to lift the clot off the wall and remove it. So it's quite interesting, but you obviously need multiple specialties working together to get this to work. So what about combining things, or what about using thrombolysis with mechanical? We kind of have 3 different examples. Power pulse is the way to use AngioJet to deliver thrombolytics, and it's very effective. I'll show you a case of that in a few minutes, where you can basically inject the clot with thrombolytic and get it deep into the clot. And then there's 2 ways you can do it. Now the standard way is you go through usually AngioJet first to remove any loose stuff, and then you go through and inject about 10 milligrams of TPA into the clot using the AngioJet, and it has a mode where it stops suction, it just injects. So you have to remember, okay, I am adding fluid. I could send stuff downstream because I'm not removing anything. And you kind of do about every squirt every centimeter or so throughout the vein or the artery. give it a half an hour, let it marinate, and then come back and angiojet, and you can remove quite a bit of thrombus. Sometimes though, when I know that, like especially for like a long DVT, I'll use this to give the thrombolytic. Instead of giving a bolus through an infusion catheter, I'll give the bolus through the angiojet and then start my lysine and just put my infusion catheter in and leave and come back later. And that's very effective. It really can get things going quickly. And I'll show a case of trellis. Trellis is a device where you have two balloons, and you have a balloon, and in between these two balloons, you can put thrombolytic in between them. So you kind of create a little chamber, and then you have an angled wire that rotates to break up the thrombus. And you do this back and forth, 15, 20 minutes, and then aspirate. And then the ecosystem uses thrombolytic infusion catheter, but has some ultrasound energy, vibrational energy to help break up the thrombus. So it's multiple ways to use both. So I kind of already explained what AngioJet works. This is a trial talking about using AngioJet in conjunction with lytics. Because it's kind of been, instead of doing days and days of lysing, possibly finishing up with AngioJet, which is a common thing that a lot of us do. And what was quite interesting, I wanted to show this mainly because in this trial they show quite dramatic and shortening of treatment times and cost. And you can see here, this is the cost of treatment was actually better. And the blue box is both using AngioJet with catheter-directed thrombolysis. It actually was cheaper because you had fewer days of lysing. And this is, the bleeding wasn't too different. Took out the one slide. So, but the time in the unit was actually was less as well. And then no, that's just the conclusion on that. This is one using using thrombolysis versus pharmacomechanical, using the two together. And this is where they're using like power pulse basically. And this has also showed an additional improvement. This is just showing some patency and how much thrombus they removed was improved. But again, on this one, you can see it in the next slide. The time in the hospital, time in the unit was much less when you used AngioJet in the power pulse form and really got thrombus, you got thrombolytic deep into the clot early. So that's quite dramatic, and you see that too. If you ever work through a multi-day DVT drip and hoping the lytics just do it all, it just doesn't. You gotta break it up. You gotta do something different, and I think starting with power pulse and then angiojetting on your next return, and then a lot of times you're done. If you started that way, my DVT times are much shorter now than they used to be. So let me show you a few cases here before I hog all the time this morning. And this is an old case, a 55-year-old gentleman who had colon cancer. His left leg was swollen. What's interesting here is he had several negative duplexes. They kept saying, no clot, no clot. And then he finally said, oh yeah, you do have a clot. And this is why. He had a left iliac vein DVT to start with. And he had probably stenosis. He probably had some probably local cancer there that was adding to it. So they don't often go up into the pelvis. And so I think they were really not looking high enough, and maybe they couldn't see. But this is a common problem where you get someone who just looks like they have a DVT, but they say no. Don't give up, don't call them normal. Just if you clinically think they have it, send them back, tell them to go higher up or get a venogram. So his iliac vein was closed, and he had all this clot all the way down. We went contralateral in this case. We don't usually do that, but we went all the way down, and you can see all this loose clot, and you can see the valves here that are full of clot. You see like right over here, right here, that's your valve in your deep vein. And so that was our goal, is to get rid of this. And so we crossed all this and just used AngioJet, and we got rid of all this fresh thrombus. This is the stuff that just happened, and it came out nicely. And you can see the valves looking more normal, you know. You can see the normal structure there. So I think that this is a kind of a nice picture to explain that's what we're trying to do here. We're trying to get the valve function back so they don't have post-thrombotic syndrome, and they'll do better. This is quite interesting, though. His iliac vein definitely was a source of everything. So this picture on the left is after overnight thrombolytics at the iliac vein. So here's our wire, and there's all this loose clot here. So this is after we angiojetted. So we did an angiojet after the lytics. It's all soft. It's very fresh thrombus. It all comes out without a problem. But there's a narrowing there. We ballooned that, left him alone. But he came back with restenosis there, so we ended up actually stenting that vein later on. All right, well, this 67-year-old gentleman, left leg swelling after a long flight. So we're stuck in behind his artificial knee there, and he's face down. This is his left leg. And lots of clot throughout the thigh there. Oh, I went too fast. And then this is just showing it without, you can kind of see that the clot all the way up near the groin. And this is the iliac. You have a big filling defect and really no flow, and you immediately get to collaterals. So it's an interesting thing. Clearly he's got something going on in the left common iliac vein, but he never had a symptom, a problem until recently. So it's kind of interesting. So we went through that without a problem. We deployed a filter up top. I think this is a Cook Select filter. So we did this from the knee with popliteal, just went through it, just said, you know what, there's a lot of clot, bunch of clot in the iliac vein. I like to put a temporary filter in. You can see the little hook at the top. This means take me out when you're done. And then we used trellis on this. So we went way up, we put the first balloon clear in the IVC, second balloon down here. You can see the little wiggle wire. I'm sorry I didn't get you a movie of it, but it basically spins around, and you can kind of alter the position of the bend in the wire. And we did this at multiple levels all the way down. And after that, it didn't look a whole lot better, but there was a little bit of improvement downstream. But as we were kind of exchanging, we kept getting clot out in our guides. So I put an 8-French guider, multi-purpose guider, all the way up. And I just sat there and pulled clot out for a few minutes. We got all this clot out over and over. So as you can see, this is just a picture from down below, but we got a little bit better, a little bit better. We got better, but we had a little flow here, and we just kind of removed a bunch of stuff, and then we lysed it. And then when we came back, things looked quite a bit better overnight. Pretty good flow in the leg. But when you get up to the pelvis, we still had a problem. Lots of clot here. Lots of clot here. And so then what we did is we angiojetted the soft stuff out. But you can kind of see in this picture faintly, there's our filter, IVC, the other side is over here. There's something going on at the left common iliac. So this is after AngioJet, it's looking cleaner. So what we did is we did IVUS up there, and you can see he really had quite significant proximal venous obstruction, or May Thurner. This is totally squeezed down. I'll show you an example. This is right here. So here's a good looking vein, totally pancaked, and then here's your inferior vena cava. And if you compare this top IVUS is, wrong, too many tools. This is the inferior vena cava. This right here is not the vein. This is the right common iliac artery squishing the common iliac vein, and here's the spine. And over here is the external iliac vein. So very classic May Thurner. So from the groin, we shoved a big wall stent across this, and you can see it. This is a 16 by 90 wall stent. So we started up in the inferior vena cava, came across that area, and you're really just starting to splint open that spot. And we ballooned it, and it looked much better. So with these sorts of stents, it's not like when you stent most other things. You have such a size difference between the IVC down to the common iliac vein. I've heard a lot of opinions on sizes. Some people just pick huge stents, 20s, 22s, throw them in and don't worry about it. I get a little nervous putting too big a one in the external iliac vein or common iliac vein, so I tend to match a little closer to that and not worry about the IVC. It's like an extra filter. And so afterwards, this is what you want to see, a nice circle all the way down. And you can see this is the stent right there. And and what was really great about this is he was in the hospital, I think 2 days maybe. Came in, had massive clot. We power pulsed, we did all this, we got all this lysis, we angiojetted, we fixed his iliac vein, he's done. Went home, Xarelto, boom, gone, very quick. And this is coming back a few weeks later, pulling his filter out. All right, one more quick one here with a clotted stent, just to kind of give you some idea of a power pulse in the artery. Here's Viabon, and I think actually this might be an atrium stent up there. I can't remember. We put a lot of stuff in this poor person. totally thrombosed. We get across it. So our first picture here is after AngioJet. So we get a little bit of lumen. And then we went through and did power pulse, and this is after a power pulse. So you see we have flow, but there's still kind of a couple millimeters of junk there out to the stent. So we went ahead and lysed this overnight, and after that, then we got really the rest of the clot out, and it looked fine. And actually everything is open all the way down. So, all right. So just in conclusion, with DVTs, I really think you should be aggressive. I think iliofemoral DVT is a very good reason to do intervention. I think you should really think about using AngioJet as a power pulse delivery, either as a single setting or with DVTs to help you to give your bolus dose. I think it works really well, and it will definitely shorten your treatment time, and it's safety too. I think the risk of thrombolytics goes up the longer you give lytics, and if you can have 1 day, it's much safer than 4 days. So, and also I believe the same thing about arterial thrombus. So. All right, any? They've added some stuff. I won't make you read this. All right. All right, thank you. Any questions or comments? All right.
Thank you, Jack. If I could have my slides brought up. I'm Tom Shimshak, and I'm pleased to be here this morning. I want to thank Bayer for sponsoring the breakfast symposium. My task is to review with you the JETSTREAM thrombectomy and atherectomy device. At the outset, I want to disclose that I do have a relationship with Bayer. I've been involved with the JETSTREAM device since its introduction in this country. In addition to being a speaker for many programs on their behalf, I'm involved in training programs for them, serve on their medical advisory board, and have been a clinical investigator in some of the trials. So my task is to review this device in terms of clinical trial data and try to share with you my perspective on how this device can be implemented into your everyday practice. For those of you that are not familiar with this device, this is an over-the-wire 135 centimeter shaft length high-speed rotational device. It spins at about 70,000 RPMs. It's an 014 based system. All the devices are 7 French sheath compatible currently, and they all have an integrated front end cutter with dynamic aspiration. Those are the key components of this. And 2 of the devices that we'll look at do have the ability to expand the cutter size and profile, but all use this simple power monitor system which is off the table, and then this handheld unit which is integrated on the sterile field. If you look to the right, these are the current sizes that we have available in this country. The fixed cutters are the 1.6 millimeter and the 1.85 millimeter devices, primarily designed for below the knee. And then the larger devices, which are also 7 French compatible, are the 2.1 millimeter, 3 millimeter expandable cutter, and then the large version is the 2.4 to 3.4. So if you look at the latter 2, they have the unique property of expanding the profile based on the direction and torque that the device delivers. In one direction, low profile with the blades up, spins at the opposite direction, and thereby increases the cutter profile with the expandable burrs. Regardless of the device, a key component is the aspiration port. It's fundamental to the effectiveness of the design of this device. It allows you to remove particulate material that's generated as the device is being advanced, and it's really responsible for this device serving as an effective thrombectomy device. This graphically depicts how the device works. It's an over-the-wire system. The device is manually advanced to the target lesion. The device is activated, and as the device is spinning, it's a slow, methodical to and fro movement to debulk and aspirate and remove thrombus. And it's a slow passage of the device, and I can't emphasize enough the importance of the technique with this device. You saw some cases done yesterday and in previous meetings which will demonstrate very effectively the appropriate technique with this device. So key components of the effectiveness for all the different sizes is the differential front end cutting, the dynamic aspiration, which effectively removes particulate material, thrombus, and thereby reduces the risk of distal embolization. The aspiration component, as well as the rotational component, effectively confer an increase in the final cross-sectional area than you would predict by the physical properties of the device alone. And this is based on early IVUS data, which has been borne out in subsequent IVUS analysis. And on average, you'll see about a 40% gain in cross-sectional area beyond the predicted size of the burr alone. The device is highly effective for all lesion morphologies, and I'll work through that momentarily, but it's effective also for eccentric as well as concentric disease. This is an important trial to remember. This really led to the approval of this device in this country. This is a European trial where the device was initially evaluated, and this has been published about 5 years ago. This was a safety and efficacy study to assess the JETSTREAM device for the treatment of infrainguinal arterial occlusive disease. 172 patients were enrolled, 9 study sites with Rutherford class 1 to 5 ischemia. The inclusion criteria were stenoses greater than 70%, less than 10 centimeters in length in the femoral popliteal distribution, less than 3 centimeters in the infrapopliteal circulation. Vessel diameter was 3 to 5 millimeters. Those patients who had reduced life expectancy, intolerance to antiplatelet therapy, recent CVA were excluded, as were patients who had in-stent restenosis, severe angulation, and very compromised distal runoff. As you can see, that although the cohort was predominantly femoral popliteal disease, about 37% of patients did have popliteal or infrapopliteal disease. In terms of lesion and patient characteristics, mean lesion length was 2.7 centimeters. Pre-treatment percent stenosis was about 80%. Post-atherectomy alone, the diameter stenosis was reduced to 35%. Final diameter stenosis with either balloon angioplasty, which occurred in the great majority of patients, or in a limited cohort, stenting, was 21%. The run times were 3.5 minutes. The procedural success was 99%. Interventional success, 99%. And as I said, stent usage was by design discouraged and represented 7% of the total treatment group. These are the major adverse events at 30 days. No significant adverse events. 2 patients did require amputation, and I would note that these were planned amputation prior to the initiation of the procedure. So a total adverse event rate of 1.2%. If you look further at device-related serious adverse events, the reported embolic event was 1.7%, and I would note that by design, distal protection was not utilized systematically. Dissections occurred in less than 1%. No perforations occurred in this early experience, and abrupt vessel closure was less than 1%, as was urgent target limb revascularization. Looking at longer follow-up at 6 months, major adverse events occurred in 19% of patients. However, 81% of those represented patients who had target lesion revascularization, and that rate was 15%. So all in all, if you really look at true major adverse events out to 6 months, it was very, very low. What about patency and clinically driven TLR rates? Patency rate at 12 months was 62%. Secondary duplex-driven patency was 81%. Clinically driven TLR at 6 months, 14.5%, and at 12 months, 26%. In terms of functional improvement, as you can see, there was statistical improvement in ankle brachial index at 12-month follow-up, and a corresponding improvement in Rutherford class functional state at 12 months, again, reaching statistical significance. So the device is effective in this cohort that was analyzed. These were patients with real-world disease, but as the device was introduced in this country, we wanted to really drill down further and understand the effectiveness of this device in removing calcium. This was a study that I participated in. sponsored by Bayer, looking at the effectiveness of the device, the G3 device, in removing calcium. This is the study design. It was a prospective, single-arm, multi-center study, a registry, to evaluate the effectiveness of the G3 device in removing calcium, superficial calcium, which encompass more than 90 degrees of arc of calcium, and symptomatic lesions that were more than 5 millimeters in length, 5 centimeters in length, with the primary endpoint being calcium removal, luminal gain, based on IVUS-driven data. Secondary endpoints were major adverse events, target lesion or vessel revascularization, death, unplanned amputation, MI, and then the use of adjunctive balloons and/or stents. So there was a systematic protocol using the Volcano intravascular ultrasound system. We used an automatic pullback, and there was a rigorous protocol that we had to adhere to in terms of adequate IVUS images, because this is really fundamentally related to assessing the efficacy. So 21 subjects were evaluated with appropriate IVUS images. The lesion lengths, the lesion location was common or superficial femoral artery in 81% of patients, and 67% of the patients treated in this cohort had what was considered to be severe calcification. This is the patient demographics. Looking at the mid portion of this slide, lesion location, 76% SFA, 33% popliteal, 5% common femoral. De novo lesions, 90%. Calcium was severe in about 67% of patients. And the pre-treatment percent stenosis was 82%. Following the JETSTREAM device alone, 40% diameter stenosis. These are the procedural characteristics. The device runtime was about 5 minutes, 2 minutes blades down, 2 minutes blades up. The volume of aspirate was about 200 cc's. 71% of patients required adjunctive balloon angioplasty alone. About 24% required stenting. So let's look at the effectiveness of the device in terms of lesion characteristics and at the area where calcium was felt to be the most severe. The pre-treatment lumen area was 4.3 millimeters squared, and following the JETSTREAM alone increased to 7.4 millimeters squared. The area stenosis decreased from 66% to 35%. If you just look at the area where calcium was the most severe, and those were the IVUS images that were analyzed, same basic trends, almost a doubling in terms of luminal area from 5.6 to 9.1, area stenosis 59 to 31%, and a corresponding improvement in the calcium removal. This is a representative patient that was treated mid-SFA with corresponding IVUS images from that segment. As you can see, a concentric rim of dense calcification. This is in mid portion is after atherectomy alone, and in the final after adjunctive balloon angioplasty with a significant improvement in cross-sectional area. If you look at adverse events that were reported in this registry, no adverse events that were reported at 30 days. So this was a safe and effective device, even in the presence of excessive calcification. So what are the attributes of this device that are appealing to me, and how have I integrated that data into my practice? I think to summarize the effective characteristics and unique characteristics of this device, this is effective and safe as a debulking atherectomy device, but it's also very effective as a thrombectomy device. It removes calcium systematically and by design, and aspirates material that's generated. The luminal gain exceeds what you would expect from the cutter alone, and that's based on IVUS data. There's no question that having this device at our disposal really allows us to expand our treatment options for patients that historically have been very difficult to treat. SFA origin, where you don't want to compromise the profunda artery. Common femoral artery, which historically and traditionally has been kind of a no zone for interventional therapy short of surgery. Popliteal disease, mid and distal popliteal artery, which can be problematic. prior to some of the newer stent platforms. And certainly below the knee, this expands our opportunities for treating patients. Even if you are a traditional stenter, I believe that this device allows us to prepare vessels appropriately for optimal stent therapy. Often the SFA popliteal are excessively calcified. That's certainly true below the knee as well. And plaque modification is really fundamental to optimizing luminal gain, regardless of what stent platform you use. But that's certainly true of some stent platforms more than others. In addition to those points, there's no question that the SFA is probably the most challenging vascular bed that we deal with. And therein lies the limitations of some of our traditional therapies. Angioplasty has been associated with suboptimal early and late results. Stenting, prior to some of the newer stent platforms, has been associated with metal fatigue, fracture, which are associated with restenosis. And there are limitations for surgical revascularization in terms of early morbidity, late graft failure. So debulking is conceptually appealing. It removes the plaque, modifies the plaque, and no question improves luminal gain, oftentimes enough that stenting is not required. The other challenge of the SFA is that the disease is often quite varied in terms of its morphology, and it's often very difficult to predict based on the angiogram alone. But if you systematically interrogate SFA disease with IVUS pre-treatment, you will readily appreciate how complex it is. Varying degrees of calcification, varying degrees of fibrous disease, eccentric, concentric, and so you really can't predict based on the angiogram alone. Sometimes the clinical presentation can guide you in terms of the thrombus component. Long chronic total occlusions are not uncommon in the SFA, and we're dealing with multi-level disease in patients. And even though this device is not currently approved for in-stent restenosis, in my practice, it has been a very effective tool for treating in-stent restenosis. So it's multimodality. It combines debulking, atherectomy, and active aspiration, and therein it's efficient by virtue of its design, and it's cost-effective. It's versatile for a variety of disease subsets that we may encounter. Well, let's look at a few clinical examples of how this device can be utilized. This is a patient, as you can see on the left hand of the slide, with a very eccentric, very high-grade lesion of the common femoral artery. And there's the corresponding IVUS image demonstrating about a 270-degree arc of calcification with significant luminal compromise. So you can see, predict, if you just were to dilate this, you may see a little eccentric expansion on that non-calcified area, but this is going to be tough to deal with angioplasty alone, tough to deal with if you just wanted to stent it alone. And, I will say that prior to the introduction of this device, this is a patient that probably should have endarterectomy. But with this device, I think it expands our opportunities to treat patients with critical disease in this vascular bed. This is how we treated it, with the contralateral access, with the Navitus device, the 2.1 and then the 3 millimeter. And look at the difference in terms of cross-sectional area post-atherectomy. 12.5 millimeters squared, no stenting, just balloon angioplasty after we had debulked this, and this patient has continued to do well, now out about 2 years from the procedure. This is another sort of typical patient that we would use this device in. I'm sure you've seen patients like this at the course as well. A long SFA occlusion. There's some mild disease at the origin of the SFA, but a lengthy occlusion reconstituting just beyond the adductor. So our approach would be to recanalize this long CTO and then begin to debulk this. Slow, methodical advancement of the device with the blades down, reassess, and then make additional passes with the blades up to debulk this. And we rely extensively on intravascular ultrasound data throughout the procedure to guide us in terms of safety of the device and whether adjunct intervention is required. In many of these patients, balloon angioplasty is adequate, and that's how we treated this patient. So I'll be the first to say that you're not going to get a stent-like result angiographically when you use this therapy. But the key is to correlate the final angiogram with the IVUS data to determine whether adjunctive balloon angioplasty is going to be enough or if you do need stenting. And the net result of that approach is that you will limit the amount of secondary stenting that you place, and it's more focused stenting. And that's how this patient was treated, balloon angioplasty alone. So what do I look for with IVUS? I look for residual disease. How extensive is the residual disease? What are the luminal dimensions throughout the SFA? Are there areas of significant residual disease and dissection planes that may exist? Those are the sort of drivers of focused stenting to optimize the early and I think the long-term results. This is the first patient that we treated that had a clinical presentation of acute thrombus formation in this SFA that had been previously stented. This was recanalized, contralateral access, and treated with the G2 device, followed by balloon angioplasty. No lytics, no distal protection, no additional stenting, a simple debulking and thrombectomy of the device. And as I can't show you this obviously with the still frames, but it was very interesting as the device was passed through the lesion, there was a tremendous amount of reverberation of the device, which is a sort of a visual piece of data that you're dealing with soft material, that the device is spinning, it's creating sort of a reverberation, simultaneously removing the thrombus, but that's a key piece of information that you're not dealing with excessive fixed fibrotic disease, more thrombus. So currently the JETSTREAM device comes in a variety of sizes. The SF device, the small profile device, is a fixed cutter, 1.6, 1.85 millimeter sizes. This is ideal for below the knee, even for angulated segments. The small cutter performs very well, and a key component of its effectiveness is the aspiration component. And then you have sort of the intermediate size, the Navitus, 2.1 and 3 millimeter, and then the larger size, 2.4 and 3.4 millimeter sizes. This is the IFU in terms of the approval criteria and where this can be utilized, and I become familiar with this. I think that this is a device that you should be very familiar with in your practices. I think it would allow you to take care of patients that are traditionally excluded from endovascular techniques, and in those patients that you are treating every day, I think that this can easily be incorporated into your practice, and I think it will translate to better outcomes for your patients. Thank you for your attention. I'll be happy to take on any questions that you might have. I think we've got about 5 minutes or so. Comments or questions? If those of you that are not familiar with it, I would encourage you to spend some time at the booth, look at the device, be really comfortable with it, and try to become proficient with it. There's a relatively short learning curve. What I have found is that the device, when used appropriately, is highly predictable in terms of its effectiveness, but it's really related to technique, and really master that. Comments, questions? If not, thank you for your attention.
Good morning, everyone, and welcome to day 2 of the Chicago Endovascular Conference. We're going to be starting the general session in about 5 minutes. The venous rooms are open now, so those that are interested in the venous side can break away and go to that, and would ask that everybody in the exhibit hall go ahead and come into the general session. We'll be starting in about 5 minutes. And also, if our moderators and speakers and panel can come up to the panel so we can go ahead and get started as well. So a couple of other housekeeping items. If you're a radiology tech or nurse, make sure that you sign in before every session, because you have to sign in order to get credit. It's just the rules that we have. And we're going to be going ahead and starting the morning session, general session. Dr. Peter Soukas and Dr. Abbas are going to be moderating the session. We have an illustrious panel as well. And I'm going to turn it over to Dr. Soukas, and hopefully you enjoy your morning.
Thank you very much, Jeffer. And so as the music is introducing the session, I'd like to thank everyone for joining us here this morning. Our session this morning is complex endovascular techniques. We have a terrific panel here for you this morning. Our first speaker hails from University of Mississippi. I'm going to invite Dr. John Winscott to come up and speak to us about lost in the subintimal space below the knee. John, hopefully you're going to tell us how to find our way out.
Let's hope so. Good morning. I'm John Winscott. I'm an interventional cardiologist from Mississippi, and the vast majority of my business is critical limb. I spend the majority of my days below the knee. And so what I thought we would do today is talk about what do you do when you get subintimal below the knee? How do you get out of that situation? How do you try to cross in the lumen? And then if you're not in the lumen, what are you going to do to get out of it? Because as we treat more and more patients below the knee, more and more devices are available. The technology is advancing to help us treat these patients all the way into the pedal arch. So I thought we'd spend some time talking about that today. These are my disclosures. As you know, below the knee occlusions are very common in critical limb and are a very common reason for failure to establish straight line flow to the angiosome. I'm a big believer in the angiosome concept. Try to establish straight line flow to the wound in patients with critical limb. And long CTOs of the tibials are the most common reason we fail to do that. These are very challenging lesions, as you know. There's a lot of calcium below the knee. These lesions are often very long, sometimes 200, 250 millimeter long occlusions. The vessels are small, so when you do get subintimal, it's very difficult to have a target to get back into the lumen. The proximal caps can be very complex. You may not be able to even see where the native vessel is supposed to be, especially in the bend of the AT proximally. You're often having to work multi-level disease. You may have to cross the long SFA occlusion just to get to your tibial occlusion so you can try to establish straight line flow. There's lots of side branches, especially in the TP trunk and proximal peroneal, that make it very difficult to stay in the vessel when you're trying to cross occlusions. The veins are very close. It's easy to get into the veins sometimes when you're using aggressive crossing techniques. You're working a long way from the sheath. Sometimes you don't have enough push because you're working so far down the leg. And you don't have as many options for reentry as you do up in the SFA and popliteal segments. There are a lot of options for trying to cross long occlusions, a variety of wires, 014, 018, and 035. You can use support catheters, which is what I like to use, multiple sizes, usually 014, 018 below the knee. There are a lot of dedicated crossing catheters on the market now with Crosser and Viance and TruePath and some of those devices on the market. You always have a retrograde option, and we'll talk about some of that this week as well, using tibial peroneal distal access to try to cross these occlusions retrograde. And of course, you have subintimal reentry, which we'll talk about some today. I'm a big believer in trying to set yourself up for success. When you're trying to cross these occlusions, you need to put everything you can in your favor. So you want to take a full set of pictures all the way to the toes to see what your options are for revascularization. Look for that delayed filling, stay on the pedal, look for that late filling of those pedal vessels so you'll know what your targets are distally. You may do a selective picture inside your collateral. I believed in doing that. I'll take my support catheter down into the collateral that fills that distal vessel, directly inject into that, and that way you can really see if that dorsalis pedis or that plantar vessel fills. I always tried to find your inflow and your outflow of your CTO, and that way you consider your alternate access. If you're trying to cross a long CTO integrate, it's just not going well, I like to escalate early. Just try to go ahead and bite the bullet and go and stick the foot. And then, of course, try to identify your distal target. Are you trying to get straight line flow into the angiosome of the wound, or are you just trying to find some way to get some flow to the foot if it's just an ischemic rest pain patient? You want to get your supportive sheath in early. Don't try to cross occlusions without a good supportive sheath, either antegrade access from the common femoral or crossover technique. I'm a big believer in taking a selective picture on the proximal cap to try to define if there are any microchannels, anything you can see there to get your wire started in so that you can stay in the vessel as you're trying to cross that long occlusion. Choose your crossing strategy, stick with it, but if it's not working, like I said, escalate early, change strategies. The 50th time you push that wire in the same place, it's probably not going to go, so change your strategy early. This is an example of a patient with toe wounds, and you can see from the this is an angio at the knee. You can see there's just no tibial vessels whatsoever, and you're just like lost. You're just, what on earth is going on here? Let's see, do we have a mouse that I guess I can just use the laser. But this is the distal popliteal, and this is just collaterals. I felt like this probably represented the AT, and this was probably the TP trunk, although it's very confusing. But once I got a catheter down into the AT, I took a picture, and clearly this was a side branch of the AT, this was the AT, and it really didn't come back at the foot. So I decided, well, I'll just try to poke at it and see what happens. So I took a soft wire and a stiff catheter and just started poking at the occlusion, and lo and behold, the catheter goes. And this is a technique I really like, is a soft wire with a stiff catheter. And you can see once we inject in the distal anterior tibial, there was actually a vessel there. So after directional atherectomy, we got a really nice result, straight line flow to the toes. So this is the area of the AT that was occluded. Another patient that just has no tibials whatsoever. This is the distal popliteal. You can see probably the AT, TP trunk. This was the PT at some point, but the only thing you see that comes back at the ankle is a distal peroneal. So just very poor targets. You're like, man, I don't even know if I want to give this a shot. But I thought this probably represented the peroneal, and this probably represented the distal peroneal. So in that situation, I like to take a soft wire with a stiff catheter, loop it, and then just push and see where it goes. And so you'll see here, I just kind of loop it. This is a nitrix wire. I just loop it, push it down, and lo and behold, end up in the distal peroneal. And now we've got straight line flow to the peroneal. And this is a patient that ultimately I'll bring back. Once the peroneal has had time to fill out those distal tibials, I'll bring them back and try to open one of the tibials if their wound fails to progress. Another patient with an AT occlusion, really bad anatomy of the proximal cap because there's side branches. You just push a glide wire down this vessel, you're going to end up with the glide wire going out these side branches, end up with a perforation. So I like to loop a wire to get past those side branches. Once I did that, I could not push an 014 wire through there. It was just too hard, too calcified. So at that point, I took a stiff straight glide wire. I was able to get through that. And once we got through the occlusion, we treated it with directional atherectomy. And you can see this is the final result. Really pretty. We also treated the PT. You can see that they had actually heel and toe wounds. You can see the PT had a subtotal occlusion. It cleaned up really nicely with directional atherectomy as well. So what happens if you get subintimal? We're looking at ways to cross these lesions in the lumen, but what happens if you get subintimal? What do you do there? So this is a patient with a heel wound and a completely occluded TP trunk. You can see I tried to get a wire through, and instead I ended up on the medial side of the vessel here. I redirected my wire, ended up on the lateral side. I just was not in the vessel. So in that situation where I can see exactly where I am, rotate the camera, see which direction I need to get into the vessel, and then I like to use a stiff wire to try to get into that distal cap. And so my favorite wire for that is a Confianza Pro. So you can see I'll pull it back, redirect it, and just pop at the cap, boom, and then now we're in. And so that's just a way to redirect the wire, just try to get it go in the direction you want it to go, and then just use a stabbing motion to try to pop into that distal cap. And you can see after directional atherectomy, that peroneal looked beautiful. This is a patient who had no tibials. This is the popliteal. You can see it comes down, there are no tibials. When we took a picture at the foot, you see the posterior tibial fill up, and this patient actually had toe and heel wounds. Really ischemic looking foot. But after we crossed into the posterior tibial and took a picture, you can see there it actually cross fills to the peroneal and then over to the AT. So you see there actually is a distal AT that is a target for revascularization in this patient. The problem is you can see the proximal anatomy of the AT is not very favorable. So what I did in that situation is take a loop technique and try to get through the AT occlusion. But you can see once I get down to where it reconstitutes, I'm not in the lumen. So once again, generally when you cross these AT occlusions in the bend, you're going to end up on the lateral side of the vessel just because of the anatomy. The bend in the AT is going to push you to the lateral side of the vessel. Similar to what happens in the SFA in the canal, you almost always end up in the medial side of the vessel because of the bend of the vessel as it goes behind the knee. So again, I elected to redirect my wire. And so you can see this is also a Confianza. I pull it up, and find a spot in the proximal vessel where I can feel the cap. And you'll see as I engage the cap, I'll just make a stabbing motion right there, and now we're in. And so once we get the wire down, now we can treat the patient. I use mostly directional atherectomy. And after we treat it, you can see we atherectomize the PT and the AT, and we end up with 2-vessel runoff to the foot. Really nice result. Another patient that has an occlusion in the bend of the AT with toe wounds. These are really difficult occlusions to cross. When it's occluded in the bend, like I said, I like to take a picture selectively on the cap. Even with the selective picture on the cap, you don't see any microchannel or anything to get the wire started in. But you do see the dorsalis pedis does come back at the ankle, so we do have a target. So what I did here is took a stiff wire to try to get around the bend. Once I got around the bend, I used a crossing catheter called a Viance, and I was able to get through. It was very heavily calcified, very difficult to get through. Once I got the Viance down, you can see I'm not in the lumen. And so I don't know how well this is showing up on the screen, but the Viance is actually, again, lateral to the lumen, which is very common when you cross AT occlusions in the bend. So what I did in that situation is use what's called an anterior reentry catheter. This is a very unique catheter for applications below the knee. For those of you who do CTOs of the coronaries, it's similar to the Stingray catheter. But you just advance the balloon to the distal vessel in the subintimal space and use this special wire that comes down the balloon and is able to exit the balloon either antegrade, or here it's going to be anterior, posterior, but they're 180 degrees apart. The ports are 180 degrees apart. So you just select which port you want. Obviously, you don't want to go out of the vessel, so you select the port that leads you into the vessel. Then you just make a stabbing motion with the wire, and it pops right in the vessel. There it is. You rotate it 180 degrees so that the wire does not engage the lateral wall of the vessel here. And then you have wire control of the vessel, and then you can proceed with whatever treatment modality you prefer. So that's what we did in this situation. We were outside the lumen. I knew which direction the vessel was, so I advanced the balloon down. And you can see there's the wire as I make that stabbing motion to poke back into the true lumen. This was after multiple attempts to re-enter with just a regular wire, and I was unsuccessful. So we were able to re-enter the true lumen with the anterior, and then after directional atherectomy, you can see we got a really nice result in this AT occlusion, really brisk flow into the, stent-like result in an anterior tibia without any stents. This is a patient where they had a heel wound with complete tibial occlusions below the knee. And what we saw was the TP trunk reconstituting. We're unable to get through this antegrade, so I came up from posterior tibial access. We asked this posterior tibial at the ankle and came up retrograde, but even with retrograde access, I was unable to deliver the wire into the true lumen. So you can see both catheters coming from antegrade and retrograde are both subintimal. I can't get in the space. So what I like to do is bring the anterior up from the PT access. So here's the anterior upside down in the popliteal, and you can see I'll use that wire to pop into the true lumen and then come up. At that point, we just snared the wire, came from antegrade, treated the popliteal with directional atherectomy, and you can see we got a really nice result in the popliteal. And you can see our access side of the posterior tibial is completely intact, no spasm, no damage to the vessel was done. I'm going to skip through this case since we're running out of time. To get to this last case, we got a microchannel in an occluded TP trunk. Patient's got a toe wound, and you can see just a mess of collaterals below the knee, no real native vessels, but you see this is probably the native peroneal, and this nice collateral coming around. I was unable to get through the TP trunk occlusion antegrade. I just could not stay in the lumen. Lots of side branches in the proximal peroneal that prevent this. And so what we like to do is come around the collateral. And so this is a wire coming around the collateral vessel and then up through the TP trunk occlusion retrograde with just a support catheter. This is a trailblazer support catheter and a nitrix wire. Once we're able to do that, we're able to actually advance a balloon around the collateral, so the balloon's coming down the collateral, then up through the occlusion retrograde. We're able to get enough lumen there to where I could get a wire through antegrade, so we have antegrade flow and I can get the wire down. Once we get the wire down, we're able to treat with directional atherectomy and get straight line flow down to the ankle. So in conclusion, these are very challenging lesions. You have to put a lot of tools in your toolbox to stay out of the subintimal space to start with, but once you get in the subintimal space, there are a lot of tools available to help you get out and still be able to treat the lesion, establish straight line flow to your patient, and heal the wounds. I'll conclude there and I'll open it for any questions.
Thanks very much, John. Our next speaker is Dr. Polena, who comes to us from Italy. Dr. Polena and his partner, Dr. Manzi, are really the virtuous Italians who really revolutionized the treatment of CLI patients, particularly in diabetics, and it's a real honor and treat to have someone with his expertise with us here at this meeting. He's going to be talking about revascularization using direct SFA puncture technique. Mariano, welcome, and thank you for joining us.
Thank you so much for the introduction, and good morning to everybody. And so, yes, my topic today is the revascularization using direct SFA puncture technique. So this is my disclosure. So I want to show you some interesting point before to start is the diabetic CLI patient that in approximately 50% of diabetic CLI patients we have lesions involving femoropopliteal arteries. These are absolutely predominantly long chronic total occlusion with calcifications and with more occlusion than stenosis. And for sure, we need to analyze this, that actually we are also treating the new femoropopliteal disease, that is the in-stent occlusion. Is a new disease that we create implanting the stent. Well, to treat femoropopliteal tract, I prefer absolutely every time ipsilateral antegrade approach. When it is failed, we can consider another options. These options, this different approach, can be the retrograde recanalization using the direct SFA puncture. It's a paper published by Leipzig group. Or in cases of stent, we can consider the direct stent puncture technique. It's a paper published by us. Let me show a couple of cases, and I hope to stimulate the discussion. These are cases of Rutherford 5 patients with a stent in the pop and occlusion, long occlusion of the SFA and popliteal artery. As I said, antegrade approach in the common femoral artery, a subintimal approach with 4 French Verstein catheter and pterumostiff. Was not difficult to arrive in the stent, but for sure was impossible to enter in the stent, probably because it was in a different subintimal plane than my dissection. So after many attempts to try to engage the stent, I shift the procedure and decide to perform the direct stent puncture without change the position of the patient. I puncture in the stent in the below the knee, and perform a retrograde intraluminal or intra-stent recanalization using a V18 and again another 4 French catheter, Verstein catheter. At this point, after many attempts, I was able to engage the antegrade catheter with the retrograde and connect both axes. In the SFA, sometimes it takes time because the space is big, but it's possible, as you can see. Then I advance the antegrade catheter, entering in the stent, and continues through the antegrade axis my procedure. But as you can see, it was very tough. The occlusion was impossible to go out the stent. So to do that, I used the back tip of the pterumostiff and was able to push down the catheter and re-enter. Related to this tough situation, I deploy a filter for protection, and then after that, balloon angioplasty with this result. Direct blood flow for the SFA and POP, and direct blood flow for below the knee and the foot. So very nice result without complications. Another case is a CLI patient, diabetes, chronic renal failure, and hemodialysis, CLI, previous endovascular treatment with long covered stent deployment. This is a very interesting case for me because it was the first time that I saw something like this. I want to show you. It's a patient in which some colleagues deploy Viabam from the SFA to the below the knee popliteal artery, but really big Viabam that arrived to my cath lab with occlusion of the Viabam, occlusion of the below the knee vessels, and a recanalization distally of the peroneal and posterior, and in the foot the pedal artery. So again, antegrade access, engage the ostium of the SFA, impossibility to enter in the viaband. Also with the back tip of the pterumostiff, it was really impossible. Also under ultrasound, I saw the viaband, but was not able to enter. So I puncturing, after many attempts, I puncturing the viaband in the middle of the leg of the SFA and perform a retrograde recanalization of the viaband using the same technique and the back tip of the pterumostiff to go out, connect everything. But there were surprise. When I entering in the viaband, I noticed that there were a thrombus, fresh thrombus. So I check, and I start to perform a thrombus aspiration with a big 6 French catheter from Terumo. I perform it many times, aspirating a lot of thrombus, all thrombus, fragmented. And before to open the distal part of the viaband, I aspirate everything, then I cross and go out, entering in the tibio-peroneal trunk and recanalizing peroneal artery. It was so tough, so difficult to push down the catheter. So I deploy an 018 guide wire and change for a catheter balloon, pre-dilate everything. This was the result. A shorter coiling, so I deploy in a drug-eluting stent. This is a Create BTK for Alvi Medica, with very nice result. And after that, I recanalize in a subintimal space the posterior tibial artery, long occlusion of the posterior and the plantar artery. So subintimal recanalization in the lateral plantar artery 2. Check, the reenter was done. So I deploy an 014 guide wire in the foot. In the arch, I dilate everything, and after that, this was my result. Patency of the SFA with a bad plaque in the ostium, patency of the viaband, and direct blood flow for below-the-knee vessels, with direct flow for peroneal and posterior, and direct flow for the foot. The interesting point of this case that I hope we can discuss is the differences between viaband and the drug-eluting stent that I deploy in the popliteal below the knee. The last case is a 69 years old patient, diabetes, hypertension, and ischemic heart disease. Again, CLI, previous TMA, and as we can see, no healed. In this case, no stent, but long occlusion of the SFA with a short stamp, but good revascularization at the Hunter channel and occlusion of the below-the-knee vessels again. So good flow in the foot for the plantar side. So I was able again to engage the SFA ostium and perform a subintimal recanalization, arriving to the good patent tract of the SFA distally, but I was not able to re-enter. Look, the guide wire was really difficult to dissect, was really tough artery. So after many attempts to re-enter with the tip of the guide wire, I decided to perform the retrograde puncture of the SFA, in this case without stent. It's possible to perform this access without change the position of the patient. It's for this reason that we avoid puncturing the popliteal artery. So after puncture, I deploy an 018 guide wire and perform retrograde recanalization, and again, try to connect the both axes with a support catheter. At least it was difficult because I create two different subintimal plane, but I succeed in connect both axes, advance the catheter, deploy a new guide wire, and deploy a catheter balloon to perform hemostasis, then a long balloon, all dilatation with this result. Very, very nice, no bleedings, direct blood flow for the SFA and POP, and again, recanalization of the below-the-knee vessels, again, subintimal plane, the posterior, and again, without re-enter in the foot vessels, so retrograde access in the plantar artery, again, retrograde recanalization, connecting the both axes, and the same than before, going down with the catheter, crossing with a guide wire, ballooning, and again, direct blood flow for posterior tibial artery and for the foot with a short spasm in the plantar arteries, but this was the final result in the anteroposterior view, a very good blush for the foot. So I want to show you some result about the direct stent puncture technique. This is the population that we treat and publish it with a technical success of 98% and the clinical success of 94%. So in conclusion, we can say that direct SFA and direct stent puncture are feasible and safe options for SFA and for intraluminal stent recanalization in the SFA and peripheral segment. Based in our experience, they provide positive technical and clinical outcomes with low complication rates. The frequent complications could be distal embolizations, more frequent in the stent treatment. And the drug-coating balloon can be used to treat in-stent restenosis after direct stent puncture technique. Thank you very much for your attention.
All right, moving along. If I could have my slides, please. While we're getting my slides up, Mariano, quick question. With regards to the SFA puncture, what is your primary method for hemostasis? Are there ever any issues with bleeding into the thigh?
We try to perform the hemostasis, dilating the artery with a balloon in front of the axis. 5 minutes, 6 minutes usually is enough.
Okay, terrific. Okay, we're going to switch gears a little bit and talk about comparing and contrasting bare metal stents and stent grafts for long SFA disease. And what we're really talking about is how do we treat a patient like this? This is very common type of patient that we see in our practice on a day-to-day basis. This is probably a 30 or 35 centimeter stent. And so we have two very good and effective treatment strategies for acutely getting this artery open. We have bare metal stents and we have Viabond stents. And in what we do for a living in the real world, we always like to make analogies and parallels with the sports world. And so, of course, we're all gripped with World Cup fever. And I thought there was some interesting analogies between the Brazil and the Germany match that occurred earlier this week. So we know that for SFA disease, stents do work better than balloon angioplasty, but it's important to remember in these randomized controlled trials that I have listed here that these were all less than 10 centimeter lesion lengths. And it's important to recall that the results with longer lesion lengths are a little bit different, and so obviously they're not going to be quite as robust, but they still are very respectable. I would draw your attention to the fact, however, that with longer stent lesion lengths, we do see a greater incidence of stent fracture, and obviously that poses a whole set of different problems. The Supera stent has really been sort of the darling of a lot of key opinion leaders in the last couple of years. This is a different type of stent in that it's woven and not laser cut, has a great deal of flexibility. But you can see that even with the newer stent designs, there are drop-offs in primary patency rate with increasing lesion lengths. And Zilver PTX is now finally on our shores, but by no means is it a magic bullet. It's still an excellent stent. And you can see that with an average lesion length of 22 centimeters in the single-arm study of the Zilver PTX trial, that there was a very respectable 77% primary patency rate. Well, we're very anxious to have drug-coated balloons very soon, hopefully by the end of the year. But if we look at drug-coated balloons in longer lesions, we can see that the results are still very good. And in this particular report from our friends in Leipzig, a 77% primary patency rate at 1 year. But it's important to remember that there was about a quarter of those patients did require bailout stenting, and they, of course, excluded heavy calcification. Now, if we look at the Viabond data, this particular meta-analysis shows that primary patency rates are really quite good going out for several years. And the important thing to remember about Viabond, by virtue of its being a stent graft, is that primary patency, in fact, is independent of lesion length, and that the patterns of restenosis are markedly different. With a stent graft, you'll get a very short focal stenosis at either the top or the bottom edge, as opposed to more diffuse restenosis for a bare metal stent. Well, the Viabond stent graft has undergone a number of iterations over the years, including heparin-bonded coating, and more recently, laser trimming of the proximal end, the so-called proximal contoured edge. And this was evaluated in the Viper trial. And again, you can see this laser-cut proximal edge. And the idea behind that removal of that excess material on the proximal edge is to allow better device apposition and potentially to improve flow dynamics on the proximal end. In the Viper trial, this was a real-world trial where there were 56% of patients had total occlusions. The average lesion length was 19 centimeters, and almost two-thirds had moderate to severe calcification. And if you look at the overall results, it was a 74% primary patency rate, but it was noted that 30% of those patients had significant oversizing, as defined by greater than 20%. And you can see two examples here of oversizing, and so you shouldn't come as any great surprise that if you're putting a 6-millimeter Viabond in a 3 or 4-millimeter vessel, that you're probably going to have some issues. However, if the operators were careful and did not oversize the device by more than 20%, they were rewarded with an 88% proximal end primary patency rate and 87% on the distal end. And we can also see that with the newer device with the heparin coated, there was not a penalty to pay for using a smaller diameter device. And once again, long lesion lengths independent, the patency was independent of long lesion lengths. The 25-centimeter Viabond study results were recently reported from Europe from our colleague, Dr. Zeller. And this was a real nasty set of individual lesions. Almost 100% of these were complete occlusions and over 26-centimeter average lesion length. But despite those very adverse lesional characteristics, a very respectable primary patency rate of 67% at 1 year and a freedom from TLR rate of 78%. But really the mother of all randomized trials for these long SFA stents is really the ViaStar, which is a randomized study of the stent graft versus bare metal stents. And again, a real-world study, average lesion length 19 centimeters, almost 80% of them were occluded, 72% were task C and D. And again, you can see a very dramatic difference in primary patency between the two groups, particularly in those who had lesion lengths of greater than 20 centimeters, 33% versus 73%, very dramatic. And if you follow it out to 2 years, you can see the bare metal group had a primary patency rate of only 27% versus 63% for the stent graft group. Again, statistically significant. In addition to the dramatic difference in restenosis between the two types of stents, there were no differences in the rate of occlusions and acute limb ischemia. I think one of the myths that hopefully we finally will dispel is that when a Viabond goes down, it goes down hard. It actually turns out there really is no difference in the incidence of acute limb ischemia between a bare metal stent and a Viabond stent. Well, what about in-stent restenosis? Without a doubt, that really is the Achilles heel and what frustrates us about using stents in the SFA and popliteal position. We know from Dr. Scheinert's Festo study that there is potentially a price to pay for patency with increasing rates of stent fracture. And this interesting paper from Tasako in Japan, where they took bare metal stent in-stent restenosis and then just dilated everybody, you can see that short focal areas of restenosis fared better, but still, after 2 years, only about 50% of them were still open. And if you had occlusive restenosis, your primary patency rate was really pretty miserable. Drug-coated balloons, again, hopefully be on our shore soon. Results with drug-coated balloons are obviously better than with plain old PTA, and this was a recent report from our colleagues in Italy, and the 2-year primary patency rate dropped down from about 90% to 70% at 24 months. And again, these are pretty modest, relatively short lesion lengths of 83 centimeters. And so for this reason, the Viabond has been obviously an attractive target for use of patients with these long proliferative in-stent restenoses. And there have been a number of single-center reports. We actually published a paper 2 years ago showing a 1-year 85% and a 3-year 81% primary patency rate with an average lesion length of about 25 centimeters. The RELINE trial was a randomized trial of Viabond versus PTA for in-stent restenosis, and this was completed in Europe. Again, much more of a real-world in-stent restenosis trial where the lesion lengths were about 19 centimeters. And if we look at the results, we can see, again, a dramatic difference between the two groups in terms of primary patency rate as well as freedom from TLR. So I posed this question at the beginning of my session, which was, how do I treat a long 35-centimeter SFA CTO? In this particular case, I elected to use a crosser to get through the lesion and then ballooned and placed 3 Viabon stents with nice 3-vessel runoff and excellent angiographic result. But I think this final case really will make the point of how valuable this device can be in terms of ISR. This was a 62-year-old patient of mine who came in with unstable angina and non-Q wave MI. We stented his circumflex, but he could not do cardiac rehab because of claudication, had bilateral SFA occlusions, declined to have surgery, and again, a typical 35-centimeter total occlusion, ballooned at bare metal stents, a very nice angiographic result, but he then required 4 interventions over the next 2 years because of this in-stent restenosis. We brought him back, relined him with some Viabons with a great result, and this has stayed open for the last 8 years. So I certainly don't advocate that we use stent grafts on anybody. It's very important that people be able to take dual antiplatelet therapy for at least 6 months and that they come in for the required duplex ultrasound surveillance. That's critically important. And we certainly don't want to use it in very small vessels or patients with poor runoff. So what's next for long SFA CTO? Well, the US trials for DCB are in, and again, we hope to have those available by the end of the year. The results of combination therapy with atherectomy and DCB, a number of trials, as well as with laser that are nearing completion. We'll have some results there. And the folks at Gore are certainly working on trying to add drugs to the end of their stents to make them hopefully more resistant to this edge restenosis phenomenon. And a number of people are already using combination covered stents with DCB at the ends in an effort to inhibit restenosis. We'll also be hearing later about bioresorbable stents as well as new drug-eluting stent designs. So in conclusion, the endoprosthesis with heparin bioactive coating and proximal contoured edge is an excellent device with patency being independent of lesion length. These are safe devices to use, and they do have a very low rate of stent thrombosis. When stent thrombosis does occur, it's actually pretty easy to fix. You heard Jack Chamberlain talking this morning about power pulse spray and using ECOS ultrasound-assisted thrombolysis. They usually clean up actually very, very quickly. Technique is absolutely critical. It's paramount importance to make sure that you don't oversize the stent and cover healthy to healthy, and make sure you don't post-dilate it outside the balloon margins. And Viper, I think, really confirmed the improved patency with the newer stent design. And Viastar, I think, proves once and for all that for these long SFA lesions, that stent grafting really is superior to bare metal stent. So I would say there's really no contest between the two. Thank you for your attention. Our next speaker will be Dr. Abbas.
All right.
Dr. Abbas is going to talk to us about debulking heavily calcified lesions.
All right, so we'll switch gear a little bit and we'll start talking about debulking, and especially in calcium. First of all, to start with, who are those people that we should be aware of having heavily calcified vessels? Advanced age, diabetic, and chronic kidney disease. And I think the majority of our patients fits in these categories. Simple definition of calcium, the way I look at it, if you have more than 1 centimeters on a normal X-ray before injecting contrast and on both sides of the vessels, that's definitely severe calcium. And if it is less than 1 centimeter on one vessel, that's moderate, and anything less than that, it's mild. So angiographically, sometimes trick us. If you look at this lesion on your left side, you'll see that it looks like to me like a soft plaque. If you do a CAT scan, there's more than 50% calcium, and that's something we should be aware of. In the other side, if you look at this X-ray, you will see like strain wreck, severely calcified by X-ray, and if you do an IVUS, you see that IVUS looks like the lumen is fine. So the concept is it can go both ways. There is some intimal calcification, which is the the complication happen versus if you have a calcium in the media. This is something, we can treat with different modality, and that's something to think about when you choose your device. So why calcium is important? Calcium is important because it's really challenging for any intervention. It's unable to cross the lesion, failing of a stent or a balloon or any device you use. It has higher complications, and also the long-term outcome of your procedures. It's also affected by how much calcium your patient have. This been studied before. Any balloon angioplasty, there's 74% to this dissection. Even if you don't see it, if you do an IVUS and there is a heavily calcified vessels, it's about like 70 to 80% you'll perform dissection, and that's something to be aware of. So again, increase adverse events in general, dissection mainly, decrease the success of the balloon angioplasty, and also decrease success of stenting. That's why we respect calcium. So we have 4 devices in the market. As you see, this is all of them, they've been studied. The first one, let's talk about later. It's a great device. I don't think it has a great place in the calcium, however, great in thrombotic lesion or ISR. JETSTREAM is another device. It's a front cutter. It has an active aspiration. It's a device that's good for like tortuous vessels, and it's been studied before. There is one trial. It's a non-randomized trial, but they studied the efficacy and the safety of this JETSTREAM in calcium vessels, and it showed a good results. About 50% of those patients, they were severely calcified. EV3 published a recent sub-analysis for their definitive LE trial and in heavily calcified vessels, and about 50% of those people, they were calcified. The conclusion, of course, this is not randomized. The conclusion was this is a safe and effective device. So if we talk about directional atherectomy in a calcified vessel, of course you obtain a large lumen. You can ability to place a filter, and especially in the place you can use it in the place that you don't want to stent. Definitely, the device by itself is sometimes difficult to cross, and that's, I think, the drawback of this device. So you may need to predilate or use a different device. So you choose depends on your patient. This is a claudican patient, young. The surgeon was on vacation, so we did not perform endorectomy. I'm kidding, but this is we crossed the lesion, put a filter, and we perform a LSC. Results is okay. If you have a lesion like this, it's a calcified vessel. It's simple, easy, and you see the amount of the calcium that you can get out of this. This is a claudicant also patient. I choose not to put a stent in. I just did a balloon angioplasty at 2 atmosphere. When you have a total occlusion, the way I think about it, this could be thrombotic. So you can cross the lesion. Sometimes I put an aspiration catheter to see if there is any clots, and after that, I don't know if I'm going subintimal or like true lumen. So I chosen this to debulk with a atherectomy after a directional atherectomy if I put a filter in and a simple balloon angioplasty for this patient who has a critical limb ischemia and a single vessel runoff. This patient has a focal calcified lesion, you can tell, and the way that we look at it, if I like to use my filter when I do an atherectomy in a heavily calcified vessel. And if I'm able to place that filter, usually I go with directional atherectomy, especially for a large vessel like the popliteal or the SFA. In this lesion, I chose a short nose. I was able to put my filter wired in the distal pub, and I was able to perform a directional atherectomy. If I was not able to use my filter, probably I will change my technology. And when this patient have a bilateral iliac bypass, and I have to come from the arm, and that changed my approach by going with a smaller device and do like small cuts and the simple balloon angioplasty in this area, which I like not to put a stent in. And again, I emphasize that when you treat a calcified vessel, there is definitely there is a lot of debridement, there is a lot of calcium. So I think filter is a key, especially if a long occlusion. The orbital atherectomy, I think it's a great device for calcium, heavily calcified vessel below the knee, especially that's what I like to use it. And it has a little bit drawback about the luminal gain, but also sometimes, with balloon angioplasty and of course the distal embolization. All their studies from the OASIS all the way to the compliance, I think the vessels were heavily calcified. 92-93% of the people, they were calcified, which is really a large amount. And it showed a little benefit, and there is also patency benefit when you debulk these heavily calcified vessels. So, for example, when I use this, I mean, a single vessel runoff in a very small vessel in the distal, I think you cross it with a wire and you spin it with 1 to 5, great results, no dissection, you debulk this, and I don't think you can use any other device better than this device below the knee. This is a patient of mine that we done a couple of weeks ago. We were unable to cross with the 035 trailblazer, so we had to go with a stiff Astada wire, and we did a pilot channel with 125 crown, and then we have to go up to a 2.0 crown, and this is a 6 millimeters balloon, widely patent. There's a residual stenosis. I choose not to stent it, and I'll follow them clinically. This is an ischemic foot. We'll see if this will heal. Another patient, the surgeon also was on vacation here, and we were unable to, always subtotal occlusion of the common femoral artery, and we were able to cross it with a wire, unable to perform even 035 catheter didn't cross. We did a pilot channel with 125, and then we went up to a 6 millimeters balloon, 2 atmosphere, widely open, and you can see the picture that still there is like some calcium, but I think this is in the wall, so that's angiographically, you can't tell for sure, but I have I have a balloon inflated at 6 atmosphere, it's with no residual stenosis. So how I choose my device, in summary, you look at the patient first and you look at the lesion. Is it a thrombotic or non-thrombotic? Now, are you able to cross this lesion or you're not? And if it's a CTO, for example, are you intra the lumen or you're subintimal? Because that will decide, that will choose or change my approach. Where is the location of the lesion? It's an area that I can stent or not. And what size vessel I have? Whether a small vessel below the knee, above the knee? How much calcium? And a severe calcium, maybe I will go for something heavy, like I want to drill it and probably like do a CSI or something like that. And the runoff, if the patient has a 3-vessel runoff, I'm like not very worried. If it's a single vessel runoff, probably I need a protection device. You can use a protection device with orbital atherectomy. It's off-label, but we've used it before. And the last thing is, of course, you're going to look at your patient and you see what I'm trying to achieve here. Am I treating like a 90 years old with ischemic foot, or I'm just treating a young guy with claudican that I need to have a luminal gain and stuff like that, of course, the risk and the benefits. Thank you.
Thanks very much, Dr. Abbas. So while we're waiting for Pittsburgh to join us, I would just like to ask the panel a couple of quick questions. First of all, I think it's important to remember that if you are going to use orbital atherectomy in long, very heavily calcified SFA, to consider the use of an embolic protection device, you can use a NAV6 Abbott Embo Shield and in an 017 Viper wire, and so you can use that particular combination. I actually wanted to ask Dr. Winscott, you use a lot of soft wires, and I wonder if you, and I'll also ask the rest of the panel to chime in about what you think of the Astato wires and where they fit in for crossing these difficult below-knee lesions.
In the last about year and a half or so, my practice has completely changed the way I cross these tibial occlusions. I used to use very stiff wires and found myself subintimal a lot. I found that when I use softer tipped wires with stiff support catheters, I tend to stay in the lumen much more often, and then I just use the stiffer wires to re-enter. I really like a soft tip, nitinol tip wire with a stiff support catheter to cross these. And I have a lot, I'm from Mississippi, we have a lot of calcified lesions, and I was very surprised how successful you can be with a very soft tip wire, as long as you support it well with a stiff catheter.
All right, it looks like we're ready to go live from Pittsburgh. We're going to be treated to a great case this morning with our colleagues, Dr. Mark Woolley and Dr. Gus Ellis, 2 old friends from Pittsburgh days from 20 years ago. So this is a a special treat for me to see the Berg in all of its glory and all of its bridges. So if you folks are ready in Pittsburgh, we've got an excellent panel that's waiting to see your interesting case. So Mark and Gus, take it away.
Welcome to Pittsburgh, guys. I'm here with my partner Gus Ellis on my left here, Mike on the table here, Abdul, one of our fellows, Marion, one of the helpers, Ed. So we have an entire team here. And I'll run through this case with you. A 62-year-old male we've seen on a prior occasion. He has a stent in the right SFA, and the stent is reached the nose and shut down. He's totally occluded at the stent. There's also occluded distally to the stent. Popliteal is intact, and there's infratibial circulation. Looks pretty good, at least 2 vessel outflow. So that's not the issue. The issue will be coming into the stent. Can we run the angio? You stop when I tell you. So, you see the origin stuff about common thermal is okay.
Do you all see the angio?
We don't see the angio yet.
Does everybody see the angio?
Not yet, Mark.
Do you have the angio online? You should have.
Okay. Backup does.
We see it now.
Yeah, that would be good.
All right, hold
Okay.
on, hold on there. Okay, so you see the SFA, deep thrombosis page, you can see the SFA coming down, the one more notch, Gus. Right there. Well, you see, everybody doing total occlusions always has this issue, is that lateral's coming right off the SFA. And frequently, when it's almost a 3 millimeter vessel, you have to navigate around that to get into the stent. So we think that's possible. I think that's, you can see the hookup. The hookup occurs in a pretty satisfactory place, obviously proximal to the ductal canal. So that's the goal here. And we're going to see if we can primarily recanalize this. We have a quick cross at the top, and we're going to go through with a glide line. So let's see what we go from here. Okay. So,
Glide bar?
glide. So we'll put a glide bar in, use a regular glide bar, begin with this, we'll go to the stiff, but for the time being satisfied, just do the regular. Okay. All right.
Mark, I wonder if you could tell us what the distal runoff looked like. We didn't see that angiogram.
Moving us down to the stent.
Mark, they're asking about the distal runoff.
Distal runoff's fine. The distal runoff is fine. We have at least 2 vessels in particular flow. I can show you that. Hold on.
I need a torture here.
It's not about using a crosser here, but use mostly the
Do you have the image on the screen? Your screen?
Right.
You all have the image on your screen.
That's what they're seeing right here.
Can they see the image?
Yeah.
Yes, they have.
Right there, hold on.
So while Mark is working through this lesion out, I'm just going to ask the rest of the panel. This is obviously a challenging case of an occluded bare metal stent. If we could just go down the line and just get everyone's opinion about how they would approach this. Mariana, why don't you start us off?
Peter, I tried to do the same thing what he's doing, try to cross with the wire. Now the question is there's no distinct technology available to treat the in-stent stenosis or occlusion. We also have to look at whether he has thrombus burden load or restenosis because of atherosclerotic plaque. So idea is to cross the area, assess with IVUS to see whether you have a thrombus. If there's a thrombus, then go ahead and TPA or lyse that area, and then followed by balloon angioplasty. If the lesion is resilient to balloon angioplasty, then either a covered stent, such as Vibon, or stent-in-stent procedure.
I think that when we succeed to cross the lesion, treat the in-stent restenosis with the drug-coated balloon is, in my opinion, the best option. In some cases, cases that were showed during the Congress, the bulking before drug-coated balloon could be considered too.
Yeah, I agree. I would cross this as they did with the leaf wire, and I tend to debulk these with directional atherectomy. It's obviously off-label, just try to debulk a lot of that. A lot of times with just a debulking, you get a lot of tissue out of these stents. A lot of it will depend on the clinical presentation of this patient too. I mean, this could be stent thrombosis. You always keep that in mind. You could use, thrombectomy in that situation. But most of these are just claudicants that recur. You debulk them with directional atherectomy and then balloon, and then hopefully drug-coated balloon or some type of other drug delivery in the future.
Anybody use a filter in here right out of the gate?
To be a high clot burden, I like to take a Clearway balloon and infuse epsixamide, and then that often, you get straight line flow. And but when you have a stent that's occluded, I think a filter is a great idea.
I don't know if were they on? Did they hear what we did before?
Yeah, they were able to get there.
I think this would be a good application for the laser, stenosis, and possible thrombus. So I think I would cross and then laser and then probably angioplasty with the balloon.
That's a great segue to one of the talks later today. Dr. Eric Distal, who's a national PI for the Excite ISR trial, will be sharing some very exciting news regarding the Excite ISR study, which was recently completed. For those of you who aren't familiar with that study, it was a 2-to-1 randomized study of laser PTA versus PTA for the treatment of bare metal restenosis. The study was actually terminated early because of the favorable results with combination therapy.
Chicago, can you hear Pittsburgh?
Yeah, we're not really
Who's the moderator?
hearing Mark and Gus.
Do you have any questions? Yeah, they
Okay.
just acknowledge they cannot hear us.
They're on now. Go ahead, Dr. Woolley, go ahead and talk.
Okay.
Let me tell me if you can hear him.
All right, can you hear us now?
He's talking.
Yeah, could we increase Dr. Woolley's mic? It's very difficult to hear him.
You pump up the volume.
Pump up the volume.
Yeah, we're trying.
All right.
Can you hear us at all?
Put this over my left ear.
That's a little better.
Here, put this over my left ear. So I don't hear
You can hear us now?
Left ear.
Yeah, he said.
Yeah, we can now finally hear you.
Left ear.
Put it on his ear.
I'm on left ear too.
Yeah, I don't know if you all saw
Okay.
the screen. We were able to pass through the occlusion with the glide wire.
All right,
We have a quick cross through.
can you hear me now?
Yeah, we can hear you now, Mark. So tell us what you've done to date
Okay.
as we lost you for a couple
Okay,
minutes.
all right. Yeah, so maybe you missed what we did. Okay, did you see the original angiogram? Yes or no?
No, we're just seeing a still frame.
All right, you have not seen anything yet.
We've not seen
Right
anything
now,
you've
just
done in
seeing
the
a
last
still
few
frame.
minutes.
Did you see us going through this occluded stent?
We saw the beginning of it.
All right, so you didn't see the quick cross. So what we had was this. We had a totally occluded stent put in May. And then we crossed it with a glide wire. And we manipulated the glide wire inside the stent and then ultimately entered the distal SFA at the ductal canal. So, and then the quick cross tracked over, and we put the quick cross now to the popliteal, and we confirmed it in the true lumen. But I don't think you saw any of that.
We did not.
Did you see any of it? You didn't see anything. Okay. Can we repeat the angiogram to show what we started with? Okay, we're going to put it back on the screen, the angio when we began. Can you see, now, can you see on the image? You see this? You see it? Hold it.
We can see it now.
Go to the top. All right, now run the angio.
Where is it? Is this one?
Yeah. Okay, now you see the common femoral.
Yeah,
Hold,
repeating it.
hold, back up. All right, now do you see the obstruction
Yes, we do.
of the SFA? Okay, so our concern was that large collaterals, everybody knows, we come down there, you frequently get the collateral, you don't get into true lumen. There's a little reed nubbin, a very tiny, tiny nubbin. It goes to your right. You see just a little nubbin. So we use the angulated glide calf put the glide cap right on top of that, and then we presume a true lumen into the stent. So then we switched out for a quick cross, 035 quick cross, and we used this regular glide, this angled glide, and we then were able to pass through the stent. Initially we were in the false lumen, we got to go back to the true lumen, and we through the stent, and now we're into the down the adductor canal with a quick cross. So then we injected the quick cross to confirm we're in the popliteal. But I guess you didn't see any of that.
No, perhaps you could start from the popliteal confirmatory angiogram and then tell us where you are now.
Okay. Okay, good. Go down, show the popliteal injection with the quick cross. You have that picture? Exactly. They didn't see it. So do a DSA here.
Let's do it.
Do it scenario. Whatever's quick. Whatever's quickest. In the meantime, we'll show you the.
You're on screen.
We're on screen. All right.
Sit in a little north. North, please.
Do a scenario quick.
North.
Yeah. Inject.
Okay. Just switch to cine.
Put on scenario. So we'll see. Now, while we're doing this, to show you we're in a true lumen, we're going to ask maybe, okay, good, you can see. And he has great tubular outflow, at least two vessels, posterior tibial, anterior tibial, both present. So, so our question is now, in this fully occluded stent, we have an idea what we're going to do, but we just want to get an idea from the panel. Any suggestions from the panel?
Yeah, well, excellent break point here, Mark. So let me just ask the rest of the panel at this point, now that you've seen the angiogram, if you could just give us your thoughts about what your next step would be. Vinny, why don't you start us off?
You know, Peter, I look like he has got a popliteal puncture sheet there too, right? So it looks like he started off with a crossover approach and then put a popliteal sheet just in case he could not cross the lesion. So now the lesion is crossed, looks like. He's in true lumen. So next the options remains is what looks like after he balloons that stent area to see exactly what it will look like, and then we can proceed from there. So Mark, what is your next step here?
Okay, so that's exactly right. We accessed the popliteal because we thought this would be very difficult crossing that, and for the sake of time, we put a 4 French sheet in the popliteal, which is quite simple to do. So one sheet is there, we have a drip on that sheet, heparin saline drip, and we've got 5,000 units of heparin, so we're covered on the ACT. And I think we'll proceed now with, we're going to put a regular, we'll put a regular woolly wire down in the popliteal, and then we're going to dilate with a balloon the occluded segment and the stent and see what happens there. That's our next step. So that's what we're doing now.
Just show this, Dr.
So Mark, we continue to see the same area with your distal flow into the popliteal artery. So can we see some live flow there up top?
Do you see it now? We're on live.
All right. So now,
Do you see it?
Yes.
Okay, walk this out. Okay, then give me a balloon. We're going to use a 5 mm balloon.
5 by
12 cm.
And we'll need wire.
5
I have 120.
I have one. We got one.
Mark, while you're doing that, one of the panel members suggested the possibility of perhaps, if you think that this is in-stent restenosis, to use laser debulking, or perhaps, given the fact that this stent is relatively young, was placed in May, and are there any concerns about distal embolization and perhaps maybe throwing a filter down there?
Well, you know, that's always a concern. We don't. They weren't set up for laser here because I brought that suggestion up, especially. It might be better, but I think it's not a major situation, so we're going to proceed with dilatation. But the point on a filter, again, I don't mind putting a filter in, but the downside of the filter is it's an 014 system, and we're going to be passing a 6 French system over. Not that it won't go, but I think it's going to be a lot easier, especially through that occluded segment. I think we need to support it with 035 wire. We'll see. All right, so move on. I like the idea of filter, no question.
Yes.
You know, most of these lesions are like calcified, and there's a little thrombus. And the problem is with a fresh thrombus. So a lot of times when I cross this, I put a filter and I just run just a thrombectomy catheters, and just a couple runs, and I get all these fresh clots, and then the rest of the clot, even if it's there, is organized. So you can do. I usually do directional atherectomy, but I know it's off-label, but it's great results. But I think just a 6 French thrombectomy catheters will do the job.
Any other thoughts from the panel about thrombectomy catheters or filters or debulking?
I would totally agree with that. I have no concerns with working over no 1/4 wire here. The first thing I'll do is put a distal embolic protection device in distal popliteal, no matter what your treatment strategy is going to be. The nice thing about directional atherectomy is you can do that, not risk dissecting this vessel. If we're going to just primarily dilate this, we've already proven this patient doesn't respond well to bare metal stents. So I think dissecting this vessel, putting more stents in this patient is not the solution to their problem.
Peter, I usually tend not to put the filter right away. I really need to assess it exactly what's going on there. Is there a thrombus or restenosis? Because it basically changes the way we're going to approach this lesion. Now, if there's a thrombus, obviously you have to use thrombolytic therapy or devices which can suck the thrombus off. But if it's a restenosis related to atherosclerotic disease progression, then obviously you're left with different choices. So I really don't think so it's necessary to put the filter without exactly evaluating what's going on inside the stent.
Would anybody do IVUS here?
Yes, I like to do the IVUS. You know, once the wire goes through, I like to do the IVUS to see exactly what it looks like.
I think when you have a stent occlusion, the probability of having clot burden is pretty high. So I would just err on the safe side of, putting a filter and using, a laser device to vaporize the clot and then proceed from there.
Demag in orbit.
So for the sake of fellows who are basically attending this course and you see so many faculty members speaking different ways, you must have to assimilate this thing in mind that there are more than one way to skin a cat. So if you look at these lesions, everybody's going to treat different based on their own experiences. So when we look at Dr. Wally, he's got a ton of experience, and we want to see exactly how he comes up with. So he's not doing a IVUS here. He's just going to go ahead and balloon the lesion first to see how it looks, and which is the simplest way of starting the things off. Mark, do you do a long balloon inflation here or short balloon inflation?
We do kind of a mix. We did long for a long period of time, then we did short for a period of time, now we do intermediate. So we think a minute or something like that's good enough. I like the idea of the IVUS. I think the IVUS is pretty.
So what system do you have, 014 wire or 035 going through area?
This is 035. We use 035 alone. We crossed with the 035 slide. All right, down. Okay, and walk this off.
Hold on. We're going to dilate it proximal as well. Remember, it's including proximal.
Yeah, right.
We have the contrast.
So eject the sheet. With the ones down. All right.
See a little proximal.
Here's the ceiling here. Blue's not down all the way.
Come back.
Mark, what type of balloon do you have?
This is Anterior. Keep wire down. Keep wire down.
We'll see the wire.
Okay, now see. We're good.
All right, good.
All right, that's good. Yeah, this is 5 mm.
Stay there.
12 cm long.
No, this way. Stop.
Okay.
Stop.
You stop it. You see.
Can you dilate further? We haven't gotten to the occlusion.
Okay.
Contrast. Okay, let's see a little bit north.
Further
Further
down.
north.
Go ahead.
A little further north.
Yeah, see.
Yeah, that's diffusely diseased all through the
Yeah.
proximal segment. We're going to have to dilate that.
Dilate that, yeah. You notice that SFA is diffusely diseased up top, too.
Hold the wire.
Almost extending to the trochanter.
Just thin it there. That's good. No, stay up there.
So Mark, what are you doing? Reballooning the area again?
Oh, yeah, because we think that that proximal part needs dilated.
Yeah, all right.
Pick this up, pick this up, Jim.
Don't upset.
Marco, just want to give you a quick time check. We've got about 10 minutes left before the hard break. Not to put any undue influence on the duration of your balloon inflation, that is.
All right. Okay.
When we grab some
See those very
steps?
tight there? Yeah, okay. Now. Okay, put that down.
So it'll be interesting, obviously, to see what this looks like after this pre-dill, and as Vinny was saying,
Right.
what the vessel looks like after this balloon inflation, I think probably will dictate what the next series of steps will be.
Down, down.
Peter, if you look the original arteriogram, there's an overlap of short stent after a long stent. So it looks to me that previously they had the trouble in the same area. And when you see the balloon inflation, there is a big waste in that area. It took a long time for it to efface out. So
Okay, so, let's take this.
We have a 150 length.
it'd be tough to shoot a film with this long balloon there.
You know,
It's
okay,
about 150.
take it. Now,
What do you want to do? Take it out?
yeah, take this off. This is steady.
Jack it out. Okay.
So while he's doing that, let me ask the panel a question. How many of us use the 035 wire and 035 systems to do this?
I go 135 system.
How about you, Peter?
Yeah, we'll usually start off with an 035 system to get through. I think most of us would use a support catheter, an 035 glide wire to initially traverse these. And then, of course, depending upon what it looks like, and obviously there are a whole host of patient and lesional characteristics that go into the decision-making process about what the next and subsequent treatment strategies will be. If a patient presented, for example, with very recent symptoms, and it was previously fine and then suddenly developed recurrent claudication, obviously thrombus would have to be foremost in your mind, in which case either a jet stream or a laser and some type of filter embolic protection device would be something to think about. And also, if there is obvious thrombus there, sometimes just cleaning it up with some lytic therapy might be a very helpful strategy. Sometimes what appears to be a very long lesion after you give thrombolytic therapy may in fact be a relatively short one, and that potentially could avoid having to put in a full metal jacket.
150. Another 150.
You know, like in those long SFA, usually I try to take an angle shot because you can't see the ostium of the left side, the SFA very well here, and tend to be sometimes like a lot of disease. If you fix everything and you leave the ostium behind, this is going to come back at you. So I think you should take an angle shot and make sure there is no disease in the ostium.
Yeah, that's an excellent point. That's critically important. If you choose to put in a stent graft, it's really important to go all the way back to the ostium. I mean, that's something that Amir taught us many years ago.
Yeah, okay, we had an angle picture of the ostium when we started to do that. The ostium, mild narrowing of the ostium, nothing really. So we're okay there. All right, so we're going
So Mark, we see you have a good flow through the stent now, but you have a lesion distally and proximally.
Right. We'll stent. Hold the wire for me. So this lesion came down just about to the adjunctive canal, so we're going to stop right there. Okay.
You see the hole?
All right.
Maggot.
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 Long tapered stenosis.
Mark, hey Mark, can you tell us what you have there?
We're going to go with a smart flex. It comes out superior. We're a little concerned about the presence of the stent superior.
6 by 150 smart flex stent.
Okay, we also were geared up to the Pioneer if we didn't get through. We'll obviously go through. So okay, deploy this stent. So he's fixed this, that's good.
The SmartFlex is Cordis's new self-expanding stent. It was actually formerly known as the Flex stent, made by Flexible Stenting Solutions, and when Cordis acquired the company, they changed the name to SmartFlex. But it is self-expanding nitinol stent, and it does have lots of bridges which impart a great deal of flexibility. Comes up to 150 millimeters in length and compatible with the 6 French system. So while Mark's putting this in, let me ask the rest of the panel, would anybody have chosen a different stent or a different strategy based on that angiogram that we saw after the angioplasty?
I think the question here is what was the patient's prior, which we could have seen the film from previous to this stent implantation, because clearly here it looks like there's proximal distal disease to the stent. Maybe the stent is actually okay. So if the thought is that's the problem, I guess that's the rationale for putting stents above and below. I mean, to me, this patient clearly doesn't respond well to the previous strategy. So putting more nitinol in that patient, I don't really understand that strategy.
Yeah, I would agree. I think atherectomy and angioplasty probably is what I would have preferred. If you were going to use a stent, I would have probably tried the supera in that distal segment.
Yeah, it depends on the patients. Like if I'm treating like a 50 years old, like claudican patient, or 60 years old, this patient, I think putting more stents this patient is gonna come back, and then it's gonna be more problems, and eventually you're gonna end up with bypass. If this is like an 89 years old and I'm treating like critical limb ischemia, it's fine, you know, I can put a stent in. But this has already failed one time and it's gonna fail again, and I think, you know, whatever technology, whether atherectomy, balloon angioplasty, leave it alone, give him a shot, and see how it works. Maybe I didn't have a drug-eluting balloon, but maybe drug-eluting balloon will be the answer to this in the future.
Peter.
Mark, what was the time frame when you first put the first stent in the SFA? Because the question here is we are putting another stent in this area and how long the patency is going to be. So I think just evaluate the situation. When was the first stent placed?
They hear? Yeah, they can hear. It's just totally ignored.
What do they think about a Zilver?
Silver?
What do you think about a Zilver? Restenosis case? Anybody consider a Zilver?
Okay, let me see up top right now.
Vinny, I believe Mark said earlier that it was placed in May.
They can't hear very well at all. We need to do something with the sound system.
2013.
If it's placed in May, then, you know, it's very quick occlusion of these stents. So this patient may not do well with the other stent.
No, it's over a year.
Let me just see this stem last time you were a little.
Yeah, to answer Gus's question, I think the Zilver certainly sounds like a very reasonable approach here. Obviously, he restenosed very quickly with a conventional bare metal stent, and perhaps a paclitaxel-eluting stent would give a more durable result. Again, given the length of this disease, I think a Viabon would also be a perfectly good option here as well.
We don't want to go too high. Yeah. Right in the bifurcation, right? You need lower to lower.
Hey, Mark, is that actually a Zilver that you're implanting, or are you putting in another flex stent?
No, it's not.
All right,
Smart flex.
let's go.
So now we have full
Sorry,
metal
smart
jacket
flex.
here. Huh?
Can you hear? Dr. Woolley, can you hear them?
It's a,
Excellent, you back up.
it's a long side balloon.
That's a 4, isn't it? Yeah, let's get a 5 balloon.
5 long.
5 long leg.
Take it off, I got it. I got it, okay.
Let's take a picture.
Let's see that here.
So, Mark, it appears that you might need another stent distally, or is that just a poor outflow?
The guy got ahead of
Yeah,
us.
we got high outflow. So we'll check that out though. Let's see up top. Let's see the top. We're going to balloon this down.
How long balloon do you need?
Here's along the five.
That's it here. 5/150 or 5/220?
Come on.
150? You've got a 5/120 on the table.
Let's
No.
take it. That's not a 5, that's a 4.
That's a 5.
This is fine. Okay, put that on. Put a couple of bill faces with this. So, we'll check that distal out, but I think that's okay because the outflow is pretty fast.
Camera shot? Okay.
Yeah. Yeah, there were several questions we considered. One thing we weren't going to use atherectomy.
Take the no redundancy.
Our results with atherectomy and restenosis for stents has not been good. Even though stenting on stenting has not been great, but on the other hand, we have an option. And I was reluctant to use a superior in the stent. It could be done, but I think the SmartFlex has worked well for us. So we were very content to use the SmartFlex.
It's not following.
When you look at patency rates at the end of 1 year, talk about 2 and 3% differences. There's no startling difference in them. We go to the lower. Laura for me? Laura? Get that up.
You don't mind dilating outside of the stent?
Okay. Soft.
Mark, I just want to let you know that we're coming up on about 4 minutes left.
Okay, one thing's about.
Yeah, we need to make it thinner mix next time.
Laura? Okay, thank you. We're just going to dilate this now.
Mark, can you tell us what size balloon you're post-dilating with?
This is 5.
North.
Okay, so we're finished. You know that. You get down. Down.
Yeah, I'm trying to.
So Peter, kind of like we talked about at the beginning, after the balloon, the stented segment really looked okay after balloon angioplasty, and I think this would be a really good example of where you could use, even if you don't believe that atherectomy is a solution for long lesions. I mean, they basically had focal lesions above and below the stents that could have been treated fairly quickly and easily with atherectomy, improve the inflow and outflow of that stent, and improve the patency of that stent without really having to do anything else to the stent. So I think this is a situation where atherectomy could have been utilized very effectively and avoided a lot of nitinol in this patient.
John, I'm going to be a devil's advocate here. If you look at the lesion and you see the stent got occluded in less than a month period, I would basically suggest this patient's not going to do well with endovascular therapy. I'm kind of worried about debulking this lesion because it's so quick and you can trash the lesion down. If it's in my practice, knowing that what happened in less than a month time, I would recommend him to have a FEMPA bypass with vein graft, not PTFE, because I don't think so with PTFE he's going to do well.
So, this stent's been in since May 2013. Can you hear me?
Yeah, we didn't hear the 2013 part.
Yeah. Okay, so now, let's get a DS. Let's do a CNX. CNX quick.
Give me a 20 cc.
20 cc. All right. So you cut this down to the center.
Camera back. Put it on 10 and a half. One more. That's fast. Okay, that's good.
Obviously,
There's a- Peter,
So,
watch Peter, you see the
This time you
origin,
have to keep up with me.
what's
okay?
the origin of the SFA?
Yeah.
Blue and America.
Okay, you ready?
So there were a number of folks in the audience who were thinking about Viabon here, and obviously they were awake from my presentation this morning, so thank you to all of those people for that vote of confidence. Hey, Mark, unfortunately, we're coming up on the hard break here, so that angiography looks terrific. So I think at this point we're probably going to have to say goodbye here from Chicago, but please extend our thanks and our regards to all the crew in Pittsburgh. And with that, I think we'll conclude this session. We're going to take a quick break, and then we'll be back at 10:22. Thank you, everybody.